This talk is about whether delaying surgery for open hand injuries increases the risk of infection. We were all brought up on the dogma that you had to operate on open hand injuries as soon as possible, ideally within 6 hours, a golden window. If you delayed surgery, the risk of infection for the patient would escalate. That hasn't been borne out in the research to date, but there have been some critical weaknesses in the published studies, which I will go into now. Firstly, the majority of published studies are on very small samples. This is a problem because small samples very rarely reflect real-world data. And moreover, most of the studies to date have had an extremely short time from injury to surgery, usually just a few hours, which doesn't represent what you and I see in the hospitals, which is sometimes several days delay. Also, all of the studies to date have done what is, statistically speaking, a no-no, and dichotomized a continuous variable at an arbitrary threshold. This has a number of undesirable effects. The most important being the arbitrary classification of people who are very close to the threshold as different. Why should a person who's operated at 23.5 hours versus 24.5 hours be categorized differently when in fact they are very similar? It also inhibits your ability to model confounders, which is the other fatal flaw in the literature. If you wish to understand how time influences the risk of infection, you must take account of other factors which also may expedite an operation or increase the risk of infection, or vice versa. We sought to correct these deficits in a prospective cohort study in 2 large teaching hospitals in England. We recruited 983 consecutive patients who were subject to open surgery following their hand injury. We followed them up for a month, and the primary outcome was infection. This was defined pragmatically as any medical or surgical treatment levied for either suspected or microbiologically confirmed infection, and it had to be levied by a doctor. This histogram shows that the majority of patients were treated within 48 hours of their injury, although importantly, there is a long tail, with some patients waiting up to 4 days. On the face of it, time from injury to surgery, as shown on the y-axis, wasn't associated with the presence of infection within 28 days, i.e., the median and their variances were not different. But this is a univariable equation, and it doesn't consider confounders. So here's our mixed effects logistic regression, which shows that the adjusted risk of infection was not associated with the time to surgery. It wasn't actually, in fact, associated with any of the factors we modeled alongside time, except for skin loss, though I must confess that this could be a statistical error, a quirk, an idiosyncrasy in the dataset, i.e., a mistake. But there were a couple of other findings which we felt were interesting and we wanted to explore a little further. It seemed that the mechanism of injury and the provision of antibiotics did not affect the risk of infection. We chose to model this through effect modification, and here's a marginal effects plot. On the y-axis, we see the probability of infection. Below the reference line is a lower probability, above is a higher probability. And here we have time from injury to surgery. At the baseline, the differences between the different groups are extremely small, and their confidence intervals overlap. And over time, 3 groups converge, indicating that the mechanism of injury doesn't appear to be a strong predictor of whether or not someone will get an infection. On the other hand, patients with skin loss appear to have a sustained and increased risk of infection over time, suggesting that time and the traumatic loss of skin have an interaction. Therefore, we provide data which dispels the dogma that you have to operate on open hand injuries within 6 hours, and delays of a few days, maybe even up to 4, appear to be safe. If you'd like to read more, then you can find our work published in the European Journal of Hand Surgery. Thank you very much for listening.